Okay, thank you. Um, well, all we know that these are two major studies that focus on the role of high dose therapy. This is the PARMA study published years ago, and where they showed that transplanted patients benefit from conventional treatment after relapse in event-free survival and over survival. This is also the same conclusion from the CORAL study. And so after that, many of us moved to treat all the patients with relapse chemosensitive and some of the refractory lymphomas with high dose therapy, autologous therapy. But well, we have to consider something. We have some consideration about stem cell transplant in Latin America. First is the few quantity of stem cell transplant in America. We have very few transplants here. It's around 162 transplant around the Latin America, and there are many countries that has just one center, and that's not enough. Each center has few beds. In general, the mean of the beds from each center in Latin America are 4 to 6 beds, and that's not too much because we have a lot of patients to transplant. The third consideration is that we have a few transplant doctors. Hematology became a specialty that in many countries is not very interesting to study. So transplant doctors are needed. There is a lack in nurse and skilled health personnel also. And you also know that we have many and a lot of patients to transplant. And those patients are most of the time in a low socioeconomical situation. The other situation that we have is the late referral of that patients coming to a center. And many of them are very sick and very bad to perform a transplant. Well, this is the Central American Caribbean status in hematopoietic stem cell transplant. We have here a population of 74 million people, just 16 centers for that population. That is very few. We, in general, in Latin America, have a transplant over around 10 to 20% of the need from the need of transplant diseases. When we compare that with European countries, with the mean of European countries. We have countries that they don't have even a center, like Nicaragua, Honduras, El Salvador, and Haiti. Well, when the patient arrive, we want that they became, or when we want to put him in a win-win situation. That means that we need to know very well what kind of patient is, and so that's the Soror index that help us to make a lot of studies to put the patients good to receive the transplant. This is not this is also a situation when we take out some patients because they have a lot of comorbidities, and eventually we don't take those patients with a high Soror index. Well, that's not. This is another consideration to take, is that when that patient who is a candidate, now we have another problem, which is VCNU is a little problematic to have it. And so we change our protocol, which the standard protocol, who was being, to many other protocols like lomustine, like tiotepa, and these are the results from Hodgkin disease when we change the BCNU with another drug. And the numbers are most of them are equal to the Beam protocol. The same situation is in non-Hodgkin lymphoma when we change, for example, with bendamustine, that we have a very good results, or when we change with radioimmunotherapy, or when we add Velcade or Tiotepa, and so still a good results. Many of the countries in Latin America didn't use the Beam protocol. They used the the BUSI protocol, which is also okay. Result from some Latin American countries has this. They are doing as good with a BUSI protocol as a Beam protocol. So another kind of situation is that we do not, in many countries, we do not cryopreserve cells. This is a study from Latin America, from people from Mexico, Colombia, Argentina, Brazil, that they show that they have a good neutrophil recovery after a non-cryopreserved peripheral stem cell. This make easy the transplant the patient. Why? Because we just collect the cells, we put on the freezer, and then 5 to 6 days after, we infuse them after the chemotherapy, and these are the results. We in Costa Rica do a Egyptian protocol, which is a cyclophosphamide, etoposide, and carbo with non-cryopreserved cells, and the results are very, very well. In fact, that protocols make more easy because the toxicity is very low, and so we are moving to another kind of situation, which is the home care transplant, ambulatory transplant. This is a Swedish study where they show that home care transplant has a treatment-related mortality less than the inpatient transplant. And so we are moving on that, and many centers in Latin America are moving because it's a low-cost procedure. Well, but we also know that we have problems after transplant. Many patients relapse. So our countries are thinking that if we do a post-transplant maintenance in multiple myeloma and some lymphomas has a maintenance phase, why do not use that in transplant? So some people are doing rituximab for chlorambucil for 2 years after, and results apparently are okay. We are going to analyze that, but seems that they are very good. In my country, in Costa Rica, we are giving 4 drugs PO: methotrexate 1 tablet, prednisone 1 tablet, cyclophosphamide 1 tablet, and chlorambucil 1 tablet once a day. Our results are pretty interesting. Hodgkin disease, 4 cases with progressive disease after 1 month post-transplant, and 3 still in CR after 4 years. And non-Hodgkin lymphoma, 2 cases, just 2 cases, 1 in stable and 1 in progressive, just the patient who was in progressive disease died, and the other one is still in CR. So maybe maintenance therapy after transplant is our area to explore. The problem is that was explored, but the French the French group, and they didn't show any difference using rituximab after transplant when they treated diffuse large B-cell lymphoma. So that this is that this is an area that must be explored a little more. Because why? Because we have a lot of agents right now, lenalidomide that we use in multiple myeloma, ibrutinib that you see that there are 5 not yet active protocols with ibrutinib post stem cell transplant, and they are another ones who can be used in that way. So I didn't talk about allotransplant, but allotransplant in most of the time we use after a relapse in auto transplant. We are not using like tandem, which is some people use with good results, auto and then an allo. I didn't talk about RIG, which is also possible treatment for patients who are refractory to chemotherapy and then also receive an auto. And I didn't talk about the role of PET also in after autologous system, because he has also a role to play there. Okay, thank you.
Thank you. Can I just ask you, I mean, you mentioned allo just now, but I mean, what is the situation in terms of donor registries in Latin America? Because one of the key points, I mean, we are finding always more donors from registries, obviously, but the genetics are different, and most donor registries are Europe, North America, so let's say.
But we have in Latin America 3 registries.
Right.
So Brazil, Argentina, and Mexico, and Uruguay. But the problem is the time to get the donor.
Right.
And so in that, people are moving to the haplo stem cells.
Haplo is actually carried out in some centers.
Yeah, there is an increase in doing haplo. Why? Because it's faster.
Yeah.
And it's good, and the results are almost equal from donor from registry.
Yeah.
So haplos are more spread on Latin America. It's increased, and maybe there are around 10 countries in Latin America who are doing routinely haplos.
In Argentina, the possibility for non-Caucasian patient to find a donor is 16%.
16.
So it's quite low. For Caucasian patients, it's high, but the average for finding a donor is between 6 and 7 months. So we made an analysis of the mortality in the waiting list, and we presented in 2 meetings here in Argentina, 2 groups, one from Cordoba and my institution, and they were similar. So it's very unacceptable. So the decision nowadays is for patients with acute conditions, mainly acute leukemias, in needing an allotransplant. An allotransplant is to find an haplo donor. So Dr. Martínez Rolón from Fundaleu, representing the Grupo Argentino de Trasplante de Médula Ósea, the Argentinian group for bone marrow transplantation, presented the results of 200 haplo transplants in Argentina, and we are finding very similar results comparing with the European and North American results. The only issue is not the early mortality. The issue would be, um, you know, progression-free survival, because we still do not know if the potency of the graft versus leukemia effect in the APLO platform is identical of the unrelated. But there are several international papers that they are claiming that yes, it is effective.
Well, I mean, that's a key point of time, obviously. I mean, that's more or less double the time that we would need to find a donor in registry. It's between maximum 3 months. So for an acute leukemia, we would search for a donor diagnosis immediately in order to have the donor ready if the patient needs a transplant.
We do the same,
do the
but it's
same.
exactly the same. We're still facing the problem. The
Well,
problem is
timing.
social and economic. Because it depends on the coverage, and because
sure.
the search is a very expensive,
Absolutely.
you know, and
Family donor costs less. Yeah, sure. No, I know. Okay, any other comments?